He's a big YouTube star.
Big YouTube star.
Yalla, let's go. Saleh, yalla.
Bismillah.
Yalla, bismillah.
Okay guys, so we'll just learn the basics of hematology, which includes how from one cell all the blood cells are formed, okay, and from there what are the diseases which we usually see. So like every cell in your body, there is one cell which we call the stem cell, right? And stem cell is the first cell from which all your cells are formed. So your skin has your stem cell, your blood has your stem cell, your neurological system has its stem cell, okay? So this stem cell of the from which all your blood lineage is formed is called hematopoietic stem cell. Hematopoietic stem cell. So your red blood cells, your platelets, your WBCs, all are formed from this one cell. Tamam? And the right word for the very commonly used term bone marrow transplant, what we call BMT, is now changed and we call it HSCT, hematopoietic stem cell transplant. So basically what we do is we take a stem cell which is hematopoietic and from one patient and we transfer it to other patient. That is the bone marrow transplant, which we commonly say we are transplanting this patient. So what are we transplanting? We are transplanting this cell. Okay. This cell has two basic lineages. Okay. One is called the lymphoid lineage and the other is called myeloid lineage. Okay. The lymphoid lineage then further makes what? A lymphoblast. So the early form of the cells are called blast. So if someone has blast in their body, it is normal. Yani a blast is the immature form of a cell. Okay. So the lymphoblast, this is the initial cell. Myeloblast is the initial cell but it does not come in your peripheral blood. If you check someone's peripheral blood, there will be no blast. So where are these blasts? In your bone marrow. If you do a bone marrow of someone, because bone marrow is the factory where you have the stem cell. The stem cell makes the blast cells. So myeloid blast, lymphoblast. These lymphoblasts, so let's say this lymphoblast, which should normally be less than 5% in your bone marrow, will transfer into lymphocytes. Okay? And these lymphocytes will be of two types. They're called B cells, B lymphocytes and T lymphocytes. Okay? The B lymphocytes then further make what? They make plasma cells. What are plasma cells? Plasma cells are factories of your antibodies. So all the antibodies you see in your system which protect you from viral bacterial infections, initially from B lymphocytes make plasma cells make the antibodies. What are the common antibodies? Do you know of the antibodies? What are the common antibodies in your blood? IgA, IgG, IgD, IgE. Everyone has its own role. So IgA is mostly associated with your ciliary membranes, like your trachea, your lungs, your urinary tract. They all have cilia. So this protects you from the someone who is deficient with IgA will have recurrent chest infections, recurrent UTIs. Similarly, IgG. What is the importance of IgG? IgG is usually in your it's the smallest antibody, and this is responsible for most of the cross antibody reaction. Like in parents, IgG will cross the placenta and go to the child. So if the blood group is different, the IgGs will be responsible to cause
then
the
we
reaction.
have to give the mother the injection.
IgG, immunoglobulin. Then you have IgM. Okay, we had one patient here which we did plasmapheresis, Waldenstone. IgM is the biggest antibody. So it can, if someone has very high levels of IgM, his blood will start to, it will slow down in the circulation. Okay. Similarly, you have IgE. IgE is responsible, just for knowledge, you don't need to retain, but IgE is related to the allergic reactions with, let's say, someone has parasitic infection, your IgE levels will increase. Someone will have IgE levels increase, he will have more allergic reactions, itching, complaints like this. Okay, so these are all made by the your B cells and the plasma cells. So what are plasma cells? Plasma cells is where we see the problem with what disease, which we have a lot of patients here in our ward, multiple myeloma. What happens in multiple myeloma? So multiple myeloma. What is the problem in we say multiple myeloma is a multiple myeloma, but in multiple, what is multiple myeloma? Multiple myeloma is a problem in which there is proliferation. So we all understand the word proliferation. What does proliferation mean? Yani there is multiplication,
yeah,
and it is unchecked. Yani your cells are multiplying, and there is no stoppage. Normally in a body, in every one of us, let's say there is a cell A. Tamam? This cell A of any, yani it could be lymphoblast, it could be plasma cell, it could be myelos. It is created for, let's say, 120 days, and then there is a mechanism that it will be killed. Like a normal human being. You are born and you are killed. There is a normal, you age, then you die. This is the way the world is living. If everyone is alive from day one to till today, there will be no space for people to live. Exactly, this is the problem in any cell. So your cell, let's say your plasma cell, it should be made for, let's say, 10 days, 20 days, and it should die. Well, let's say there is a problem, and this plasma cell is starting multiplying. So let's say in your bone marrow there should be 10 plasma cells. Now they are 100, and after 10 days they are 200, and after 10 days they are 400. It's not stopping. So when this happens, in a very basic terms, this is what we call multiple myeloma. Yani your plasma cells have gone crazy. They are multiplying, and because of this multiplication, it is creating one of the antibodies. Okay, so it's multiplying, and let's say it's when patient comes here, you will see it's IgA myeloma, IgG myeloma. So what's happening is it's creating one form of a plasma cells, which is just creating one antibody in excess, yani unchecked.
Infinite, yeah.
The problem with these multiplication is that these are not normal cells. They are multiplying, but they're not working like a normal plasma cell. They're working abnormal. Yani, let's say the function of IgA is to protect these respiratory tracts, UTI. This, yani, let's say you should have 10 and you have 20, but they are not working. Yani, they are more, but functionally zero.
Useless, yeah.
Okay, so they're useless. So you will see that these multiple myeloma patients will have recurrent, let's say they'll be coming in hospital with pneumonia. And every 1 month, 2 months, they'll be admitted with pneumonia. Why? Because their antibodies are not functioning. Tamam? So this is this thing. At this phase of a lymphoblast, when it's a normal stem cell and it's a lymphoblast, let's say this same thing starts here. It starts multiplying crazy. Yani it's not unstoppable. So you call it, you name it ALL, which is what? Acute lymphoblastic leukemia. Why do you call it acute lymphoblastic leukemia? Because there is proliferation of the lymphoblast at this phase. Yani from the stem cell, when it turns to the initial phase, it starts multiplying. So you will see in these patients that you have like 20,000, 30,000 WBCs, and they are all lymphoblasts. There is no normal cell. So, and why leukemia? Emia means anything which is in the blood. So you are saying that there are many lymphoblasts in the blood. So this is acute leukemia. Tamam? Similarly, your myeloid cells, if at this phase there is proliferation, what will happen? The same thing. There will be hundreds and thousands of myeloblasts, and you will call it AML, which is acute myeloid leukemia. The same thing. Yani you have many myeloblasts in your blood. So this is why we are calling it AML. What is the problem when we have ALL or AML? What is the problem? That these cells are not going further into their divisions. Maturation. They are not getting matured, and they are stopped here. So all of the products that, let's say, your myeloid lineage, what does your myeloid lineage makes? It makes megakaryocyte. What is a megakaryocyte? It's the immature form of platelet. Okay, so these megakaryocytes will make platelets, right? It will make your granulocytes. Granulocytes are what? Your WBCs. So neutrophils, eosinophils, these all things. And the third thing is it will make erythroblast. Erythroblast. Basically, these are all yani terms which are used. Like erythro is with red color, and then you have red blood cells. Tamam? So this will finally turn into RBCs. So your hemoglobin, your WBCs, and your platelets. If there is any problem here, because it's not maturing, it is just stopping at this phase and it's multiplying, you will have AML patients, platelets 10,000. Why 10,000? Because it's not making platelets, it's just multiplying at the initial stage. Tamam? So you will see that all of these will be decreased in these patients, and daily you will transfuse them platelets, daily their platelets will be low. Because there is no further platelets that are coming from your own factory. Do we have something to know about? Just a tissue paper. Okay, so just we remove this. So myeloma we have already covered, and where in the chart we are having myeloma, so we can have more space. Now, so this is AML. This is ALL, and here we studied myeloma. Yani basics in the long run, what's happening where. Sometimes, so we'll study AML, ALL, and you must have heard about CML and CLL. So where are these diseases happening? CML means chronic. Chronic means what? That these blast cells mature, but they don't mature completely. Yani they're somewhere in the middle. Somewhere here, they have started multiplying. What happens? These mature cells, when there is a problem in the myeloid lineage, let's say with the megakaryocytes or with the granulocytes or with the erythrocytes, you will have chronic diseases, right? These were acute diseases which were happening in the earlier phases. Chronic is one where they are mature, they are not blast cells. So let's say, I hope it's not getting very difficult. I'm trying to
No, it's basic enough. Basic enough, yeah.
So let's say the chronic diseases in the myeloid lineage. Okay, so this AML was the immature phase. In the mature phase, we call it myeloproliferative neoplasm. Myelo means it's coming from the myeloid lineage. Proliferative, it's proliferation. Neoplasm means it's a cancer. Yeah. Okay. So these mature ones, we have four diseases more commonly. One is CML, one is myelofibrosis, one is essential thrombocythemia, and one is polycythemia vera. Let's make it simple. If there is proliferation with the mature granulocytes, okay, yani they have matured, they are not initial phase, they are matured, and now they are proliferation.
Just multiplying.
So this you call CML. Yani what happens? Chronic myeloid leukemia. It's not acute leukemia. CML. Let's say a patient is coming. You see WBC counts how much? 230,000. What is normal? 4 to 12. But you are seeing a patient who's coming with 230,000 WBCs. When you will see the blood, you will see there are many immature precursors. So there are myeloblasts, myelocytes, promyelocytes, like this. ET, what is ET? Essential thrombocythemia. This is a disorder of the platelets. In this one, you will have, a patient will have, let's say he will come to you, what's the normal platelets? Up to 450,000. You will see patients with, let's say, yani 100,000, yani above 10, 100,000, 100,000, like this. What's the problem? Proliferation here. Mature megakaryocytes, platelets multiplied, uncontrolled. Okay. What is polycythemia? Polycythemia comes with the problem with the erythroblast and the RBCs. So let's say a patient will come with a hemoglobin of 20, 21. Yani normal maximum for males 14, 15, for females 12, 13. Patient will present to the emergency department complaining, I have headaches, I have dizziness, What's the hemoglobin? 21. Okay. So what's the problem? Your hemoglobin, your mature erythrocytes, they are multiplied. Tamam? So you will have a disease which we call polycythemia vera. So these are four most commonly seen myeloproliferative. Yani in this lineage of the myeloid lineage, you will have this this problem. Got it till here? Clear?
Yeah.
Any questions?
Following.
Okay. When you come to the lymphoid lineage, there are not many of the chronic disorders, but commonly what you should know. Actually, there's a lot of details, but I'm just trying to like keep things which you can get hold of. So CLL is one of the disorders where, let's say, your B cells, yani there was a stem cell, then your lymphoblast, then your B cell was formed. This mature B cells, it will start multiplying. Tamam? So when it multiplies, you will call it a lymphoproliferative. So you just divide all the words. Proliferative disorder. Okay. So lympho means coming from the lymphoid lineage. Proliferative, it's proliferation going on, and disorder is a disorder. So a very commonly seen lymphoproliferative disorder is CLL. Okay.
Mm-hmm.
So in CLL, what is happening? Let's say your B cells, the B lymphocytes are multiplying, but they are abnormal. And what will happen? Let's say your patient will come. Your WBC is, let's say, 40,000. And when you see the differentials, let's say you have differential neutrophils, lymphocytes. So neutrophils, let's say it will be normal, but lymphocytes will be increased.
Which is basically NC.
So you can have CLL, chronic lymphoproliferative disorder. Where is it happening? In the matured phase of the lymphocytes. Okay, khalas. Now your small test begins. Okay, so be prepared. Okay, let's say. So I'm making the same diagram, but I will leave gaps. This is the first question. You guys can volunteer. So it will be the easiest questions.
So wait, you said the plus cell always appear in the let's say
They are
the factory.
normally present in their bone marrow. It's a
In the
normal
bone marrow,
process.
yeah. So if it's appear in the peripheral blood,
Yeah, so that's not fine, because it means that you have so many blast cells in the bone marrow
that it's actually moved to.
that's coming out.
Mhm.
So any abnormal cell, whether it is mature, whether it is immature, if it increases in your bone marrow is just like a room. It has a limited space. Let's say you can have 100 people here. So let's say 5 people are from A, 5 are B, keda.
Mhm.
So let's say if A starts to proliferate everywhere, so B, C, D, where will they go? They will become a shortage. So that happens in any, let's say, leukemia. You will have one cell which is multiplying and you have a limited space. And you say, no, khalas, I will occupy all the space. So where will the rest go? So you will have no hemoglobin, no platelets. Keda. Chalo khalas, let's go to this one. So what is the first cell? First cell of anything. This is the most easiest question. Okay, anybody? Stem cell. Okay, so stem cell. And what do we call a stem cell which is from the lineage of blood? Hematopoietic. Okay, so hematopoietic stem cell. This is the first cell. This divides into two lineages: myeloid and lymphoid. Tamam? So you have a lymphoid lineage and you have a myeloid lineage. The lymphoid, the immature phase is called what? Blast. Blast, in any case, it's an immature form. When it's lymphoid, it's called what?
Blast.
Immature, it's called a blast. But when it's lymphoid, what blast it will be called?
Lymphoblast.
Lymphoblast. Very simple. And if you have proliferation of lymphoblast, what do you call it?
Lymphoblastic proliferation.
Acute
Acute
lymphoid leukemia.
Okay.
So ALL is here. What do you call blast from the myeloid lineage? Myeloblast. What's the condition in which you have acute myeloid leukemia? Simple. This myeloblast makes what? 3 lineages. Plus, what's coming from your myeloblast? You have hemoglobin, end product. Let's talk about the end product. What do you have in blood? Hemoglobin? And what else? What do you transfuse patients? What do you commonly transfuse? Blood and platelets and WBCs. We don't transfuse WBCs, but in actually we also transfuse WBCs, but now we don't. But previously at certain times we used to transfuse WBCs. So what do we give instead of WBCs nowadays? If someone's WBC is low, what do we give? Have you heard someone that doctor says transfuse WBCs? Have you heard? Doctor is saying transfuse WBCs to this patient. No. Right? We don't do this now, but we used to do it before. In medicine it was practiced. But now we don't.
For my
Okay?
one. Yeah.
So what do we do? If someone's WBCs are low, filgastrin. Filgastrin is what? Filgastrin, GCSF. Let's learn GCSF also. So always remember, for your platelets, for your hemoglobin, and for your WBCs, basically neutrophils. In your body there are some growth factors. Normally, there is some proteins, some hormones that will push your body to make more, let's say, hemoglobin, make more WBC, make more platelets. Normally, in case of platelets, it's known as thrombopoietin. Okay? So now we have platelet, artificially produced oral tablets and some injections that will push your platelets to increase. Okay. I don't know if you have heard of it. There are injections like romiplastim, eltrombobag that we give in DMU here sometimes to give patient a romiplastim injection. These are to push your platelets to your body to make more platelets. Okay. Likewise, for hemoglobin, you guys know of anything which increase your hemoglobin? If someone has worked in medicine, we give in renal patients, dialysis patients, end-stage renal disease. Have you heard of darbepoetin injections? Okay, so there is another injection in which you have basically factors that you give to patients to increase their hemoglobin. For WBCs, which is usually given in hematology patients or maybe let's say oncology patients, not usually given elsewhere, is GCSF. GCSF is what? Granulocyte, which is one of the mature forms of myeloblast. Colony stimulating factor. Very simple. Word to word. Granulocyte means the granulocytes. Colony, in your body there are some colonies of these granulocytes. So it stimulates those granulocytes to make more, let's say, neutrophils. Question. So let's say there is one patient with you for AML. He is recently admitted. He is in the ward. His ANC is WBC or ANC. We'll see what's ANC. Is very low, 0.1. WBC is 0.0. Let's say the patient asks you, you're not the doctor, you're covering him as the primary nurse, and he asks you that I read in Google that WBCs can be improved by GCSF. Filgastrin, it can improve. So can you give filgastrin to the patient? This is a question. Someone is ANC is low. He's asking there is something which can increase the platelets, WBCs. So can I give? What do you think? Any guess?
Did he start his actually like protocol?
He just came to you. He is there.
Well, practically it does. Practically it does. It does increase his cortisol.
It does increase. Okay, so let's say now to clear your question and answer. If someone has normal neutrophils, normal factory, let's say it's making cell A into 2, yani this is normal, but something happened and cells went down. You give the GCSF and it starts doing this again. Okay, but let's say there is a problem in this factory and there is no A cell. There is, let's say, this immature form of the A cell. Let's call it pre-A cell, yani A is before A cell. And you give GCSF to a pre-A cell. What will happen?
You will multiply the
You multiply the blast.
Yeah.
Because there is no neutrophil factory. It's the blasts that are working. So what you will do is you will basically multiply his disease. You will help his disease.
Yeah.
So in any acute leukemia patient who is actively acute leukemic, you never give a growth factor.
Yeah.
Because what it will do, it will help the blast cells to promote. Okay, so this is a very clinical point, that never give filgrastim to an acute leukemia active patient who is full of blast cells. We never give it. Okay, so this is one of the contraindication you should. Similarly, the other factors which we go for platelets, for hemoglobin, you should ideally avoid in an active acute leukemia patient. One. Let's come back to the questions. So your myeloblast will make hemoglobin and platelets, as you told, and what else? And your WBCs in simple terms. Okay. So if there is proliferation here, not in the blast phase, the blast phase has matured, and now there are some mature cells and they started proliferation. Let's say in your precursors of hemoglobin, those mature cells, what do we call it? If anyone remembers, what do we call the disease in which there is mature multiplication of the, let's say, hemoglobin?
Chronic.
It's chronic. But what is the disease? Khalas, I'll give you options. Okay, so you have CML, you have polycythemia vera, you have essential thrombocythemia, and you have myelofibrosis. These are 4 chronic disorders. So let's do it for hemoglobin. Which one of them is the problem which we see with hemoglobin? Huh? ET?
Yeah.
Okay.
It is, yeah.
Okay, so ET, essential thrombocythemia, is for platelets. Okay, essential thrombocythemia, this you have to just keep in mind. Essential thrombocythemia with platelets. Hemoglobin with polycythemia vera.
Yeah.
This is a very interesting disease actually, and you will see a lot of people, even there, I know a couple of people who you will meet, they will have these disorders and you will not even know, because these are chronic disorders. They will be taking medication and they will be with you like normal people. You won't even recognize he has CML or he has a polycythemia vera. So these patients have very interesting thing. It's one of the signs. When they start to bath with warm water, they will start having itching, severe itching. This is one of the things that the patient will come to you. And when you will check hemoglobin, 21 like this. Disorder with WBCs, with the granulocytes.
Well, PNP.
CML, all of you should know. CML is like very common blood disorder that can come to you, malignancy. So chronic myeloid, remember with myeloid,
Yeah.
myeloid leukemia. Although it's saying leukemia, but it's not like the acute leukemia as you see. Okay.
But all of them are chronic.
Huh?
All of them,
They are all chronic.
Yeah.
And what is primary myelofibrosis? Just maybe when you read sometime later, myelo means obviously from the myeloid lineage, and fibrosis means fibrosis. So what is a fibrosis? Your bone marrow, which has normal cells, because of some disorders, will start to fibrose. Fibrose means what? When you see the bone marrow under the microscope, it will be all fibrosis, no normal cells. So hemoglobin will be low, platelet will be low, WBCs will be low. This is one of the disorders that you should know. So there is one. So you can remember there is one disorder in which there is high hemoglobin, one disorder is high platelets, one disorder in which you have fibrosis in the bone marrow, and one disorder in which you have high WBCs, which is CML. Okay. This is the basics. The two remaining things, these are the malignant things. Okay. And we know one thing, that we don't give GCSF in any patients who have active acute leukemia. Two other things you will see very commonly in the wards. One thing you will see very commonly, let's discuss that, not to go into that, is ITP here in the platelets. So first we were discussing multiplication, but sometimes what also can happen, that your body is making your platelets, fine, no problem. One day some viral infection happens, something happens, and your body starts to make an antibody. But the problem in the antibody is that it's recognizing your own platelets as foreign.
Yeah, attacking to the platelets.
So he's thinking, these platelets which are roaming in my body, they are not mine. So there is like technical glitch. Okay. So it says, khalas, this person A has platelets, platelet A, let's name platelet A. But this A is thinking, no, this is not platelet A. This is not from me. This is, let's say, platelet X. I don't know this platelet, I have to kill them. This is your normal body. Yani Allah subhanahu wa ta'ala has made our body that it has a self-recognition system. That this cell is mine, this cell is not mine. But if there is a problem in this system, when it recognizes that this cell is not mine, it will start to kill it. Because it says it is foreign, khalas, I have to remove it from my system. So ITP, it's called immune thrombocytopenia. So penia means low in blood, thrombocyte means platelets, and immune means this is problem with your immune system. So your immune system is saying, khalas, these platelets are not mine, I will kill them. So how it will kill them? It will produce antibodies and it will attach to the platelets, and when the platelet go through the spleen will kill them. Okay, this is a normal mechanism. Always remember, not every patient who comes with low platelets has to be transfused blood. This disorder, ITP, is one of the contraindications of transfusing platelets. This patient will come to you with platelets, let's say 4,000. Okay? You will not transfuse them platelets unless the patient is actively bleeding. You will see ITP patients even with platelets of 1,000 sitting stably, no bleeding. So you will transfuse them platelets? No. Even at platelets of 1,000, you will not transfuse them platelets if he is known patient of ITP. Okay? Why are you not transfusing platelets? If you will transfuse this patient, person A more platelets, this immune system will be more aggressive.
Yeah, stimulate the...
Because previously it was killing 10 platelets, now it will have to give 20 platelets, so it will make more antibodies, more aggressive system to kill the platelets. So next time, let's say when the patient came, his platelets was 4, after transfusion it will be 2. Because your body, when you give more platelets, the body will kill more platelets. So before it was dropping 1 bomb, now it's dropping 10 bombs. Because they think there are many platelets, so I have to kill them. So always remember, just make sure whenever you are transfusing platelets to any person, just don't keep a cutoff. Like 4,000, I will transfuse platelets. You will not transfuse platelets because it will only create more problems for the patient. Unless you see a patient who's actively bleeding, epistaxis, or let's say bleeding from hematuria, severe. Only in that case, that is also just for support. Yani, meanwhile his bleeding may stop. Otherwise there is no role. His hemoglobin, his platelets will worsen anyways. Okay, so ITP you should always remember. This is one of the disorders of the platelets. Achha, coming, I'll just finish it like 3 minutes more. What about blood transfusion in those patients you see here with leukemia? Let's say any patient there for leukemia. Generally, keep a cutoff of hemoglobin of, let's say 8. It should be, if it's going less than 8, you should think, khalas, we'll give him. I'm talking about hematology patients. Actually, as per guidelines, 7 should also be okay. how do we decide why 7 is okay or 8 is okay and why not 9 or 5 or 2? If you go to books, there is one thing which is known as hemoglobin oxygen dissociation curve. So your hemoglobin, which is in your RBC, is attached to hemoglobin at a certain level and it dissociates at a certain level. So there are studies published that say that if you have a hemoglobin of 7, a normal person has hemoglobin as 7, he is able to carry all the oxygen
Needed.
and he is able to do his duties. What is the duty of hemoglobin? So let's come to the very basic. What is the duty? As you know your duty, what's your duty here? You know what's your duty. What's the duty of hemoglobin in blood?
Transfer.
What does RBC do?
Oxygen.
Carry oxygen and carry nutrition, and so it will take oxygen from your lungs, okay, give it to the tissues, and will it take something back from the tissues and take it back to lungs? Carbon dioxide. This is a normal mechanism. So this hemoglobin is 7 is enough for a normal adult male or female to carry his oxygen to the lungs, from the lungs to the body, and from body to the lungs, and it will perform its duty. So, but khalas, it's acute leukemia patient, we keep 8. If it's less than 8, we transfer. If it's more than 8, khalas, no need. Don't touch the patient. Platelets. See, platelets is just like something which you have excess in your body. If patient has platelets more than 100,000, okay, the patient can even have a neurosurgery. It will have no impact. What is the normal cutoff? 150,000. But even if someone has 100,000, you can do anything on it. Any major surgery, any neurosurgery. If he has platelets more than 50,000, you can do all major surgeries except neurosurgeries, because neurosurgeries is compromised space. Let's say this is your spinal cord. It's in this closed confined space. So if it's bleed, the bleeding will compress the important things. But let's say you have bleed in your abdomen. Your abdomen is very big, so it will bleed. It will drop your hemoglobin, but it will not compromise you. There will be nothing life-threatening. Okay, so you keep. Let's say I want to do laparotomy on a patient. Khalas, you have more than 50,000, proceed. I want to do a general cesarean section on a female. Khalas, more than 50,000, you can proceed. But for acute leukemia patients, platelets of 10,000 and more are safe. You will not bleed to death, most likely. Although they are cut off that above less than 20,000, patients can have significant IC bleeds. Okay, but with experience we have learned that above 10 patients usually don't bleed. So less than 10,000, if someone is having platelets of less than 1,000, don't ignore them. Try giving them platelets as soon as possible. It's not like something light, it's okay, khalas, we'll transfuse after 4 hours. No. Less than 10,000, whoever is the physician, call them. Patient has platelet low, and consider as an emergency. Don't take it like lightly, it's nothing, because if, maybe nothing will happen, but if it happens, what will happen? The patient will bleed in the brain. And if he bleeds in the brain, the patient will be in the ICU after 10 minutes and above in the heavens after an hour. And then this whole liability will come on the physician and the nurse. Why did you not give platelets when you were reported low platelets? Okay, so low platelets less than 10 in acute leukemia patient, don't ignore. Immediately you should have your reflex. The patient platelets are low, I will transfer. GCSF, as I told you, no worries with the GCSF. Another very important point is coming in my mind for a clinical thing regarding platelets. Yes, your anticoagulation. So patients, when they're coming to you, you should be sensitive about it. So most of them, see, you have two types of patients here: heme patients and onc patients. Apparently they look the same, but they have a lot of difference. Oncology, medical oncology patients, they have like renal cancer, pancreatic cancer. They have a strong tendency to clot. So if they are here and you see that there is no enoxaparin going on, make sure to ask the physician why the patient is not receiving his prophylactic enoxaparin. There have been many cases, not one, even in this hospital and other hospitals. The patient comes here, he is receiving, nobody notes, the patient is not on enoxaparin, plus after 1 week, 2 weeks, he has DVT and then P and maybe he dies. A small thing which we can do can save a patient's life. So, especially in oncology patients, hematology also, but hematology we already have low platelets and everything, patients usually don't clot. But in oncology patients, you have to be very careful. They will clot. For sure they will clot. If you don't give them prophylactic enoxaparin. And why do they need enoxaparin in the hospital and not at home? Because here they are lying on the bed. So you are immobilized. Your blood is slow. It's not flowing like normally. So, number one, this thing, that enoxaparin should not be ignored. Or any anticoagulation. Now, when do you should be sensitive that I should stop anticoagulation? In which patient should I stop anticoagulation? Any patient who is actively bleeding. Actively bleeding does not mean he did shoya and there is one drop of blood. This is not active bleed. Active bleed is like blood is coming out continuously for 1 hour. It's not stopping. This is active bleed. Patient is doing hematuria for half an hour. There is all red blood. This is active bleeding. So you have to stop. Consult the physician. This patient is actively bleeding. Do you want to stop the anticoagulation or not? Secondly, any patients whose platelets go below 50. Because below 50, it's already a compromised state. Your platelets are there to stop your bleeding. So that stopping of bleeding is not there. Your platelets are less than 50. You have to be very careful. At least if you're not stopping yourself, or it's not emergency, you ask the physician, I want to stop the enoxaparin. Do you want to continue or you want to stop? So this should be like your reflexes. So both things are important, giving enoxaparin and when to stop enoxaparin. Khalas, you have any questions regarding your patient's transfusion? Any questions, random questions? I don't mind. Like it comes to your mind, why should we be giving this? Let's say blood transfusion, we should give to whom, not to give to whom, anything, any question is coming in your mind.
With the ITB, I think they are the ones who are doing the blood exchange.
No, that's another disease. We'll keep it for some time else. I have not touched that. It's called TTP.
TTP.
Thrombotic thrombocytopenic purpura. That's also an indication of not transfusing platelets. And you will have low platelet, but that's another story. It's another whole subject. So khalas. So if you have any question, otherwise there's just one thing for not transfusing hemoglobin, not transfusing PEG cells. So in which patient you will not transfuse PEG cell? As let's say you have a CML patient or any other patient with very high WBC counts. Yani let's say he has 650,000. I've seen patients with even more, but let's say 650,000. His blood is full of blasts. His blood is very thick. It's not like a normal patient. So it's already, his blood is sluggish in his system. And PEG cell, which you transfuse, the red PEG cell is a thick, it's not like a liquid, it's a thick blood. So it's already patient with so much high count, 650,000, 700,000 WBCs, his blood is full of, let's say, thick mucus, to understand. And then you transfuse blood to that patient in addition to it. Let's say his hemoglobin was 65. You say, no, 65 is very low, we should transfuse blood. And the patient is also short of breath. But why is he short of breath? Not because of low hemoglobin. He is short of breath because his blood is so thick that his lungs are unable to properly take and give oxygen. Tamam? So it's very important to understand that someone with very high cell count, his problem is actually his thickness of blood, not his low hemoglobin. So you'll make sure that his WBCs become normalized and then you give blood. Let's say you give some chemotherapy or medicines, and let's say after 2 days, 3 days, his WBCs are now 200,000 or 100,000. Khalas, now I will give him blood. But if I give this patient blood who is short of breath with this high count, I am just worsening his case. I will give him blood and next day he will be in the ICU because I just made his thick blood more thicker. Although his hemoglobin is low. Technically, if you think, I should transfuse him blood because his hemoglobin, no, but you won't transfuse. Okay, so one indication we have learned with high WBC counts, don't give hemoglobin. The other indication of not giving platelets, okay, is the patients who is with ITP. The other thing is TTP, which he is discussing, but I'm trying not to cram everything because you will not be able to remember. So platelets, when to give enoxaparin? Every patient should get in hospital prophylactic enoxaparin, and if he's not bleeding, and if his platelets are above 50,000. If he's bleeding, if his platelets are less than 50,000, you have to discuss with the physician to stop it. Any questions? Khalas? It was, it did not
Very
understand
educational. No, it was super basic.
Yeah, so I tried to keep it basic. There are like even one topic that has a lot of details, but I don't want to just oversaturate. Any questions? With any hematology patient or oncology patients, if you have encountered before, why are they doing this? Anything? I think let's keep it till here.
You mentioned something about the IgG and IgE.
Yeah.
Those tests can actually tell us which patient will have a reaction from certain medication or
No,
Because
generally
as-
no.
as-
Generally no. But IgE, which is related with your anaphylactic reactions,
Yeah.
parasitic infections. If people, those who have high IgE levels, they tend to have reactions. They will, because this is the normal antibody which is present in your blood to cause reactions. In any case, the other thing, IgM. We just had one patient here. His name was Ibrahim Al Akhtar.
Yep.
He had a lot of IgM in his blood. Okay, so we did plasmapheresis. What is a plasmapheresis? It's nothing. You just attach a machine to the person, pass his blood through the machine, okay, and you take out one component from the blood and return the rest of the blood. This is plasmapheresis in general. Yani, what are you doing? I'll just add this thing also because this is important. We have a plasmapheresis machine. Okay, pheresis machine. It was down there today also. If you guys went down on the first floor. So what is a pheresis machine? Pheresis machine is a simple machine, and you can do a lot of things. So you give blood to the machine, and there is a filter. Okay, and the blood comes out. This is the patient. So you are taking blood from him. It goes in, filters, comes back to the patient, just like dialysis. But what are you filtering? Is basically explaining to you what is the problem. So let's say someone has a problem in his plasma. Okay, someone has let's say a lot of IgM. So IgM is there in the plasma, it's not in the hemoglobin. So what you will do, you will put a filter that takes out the plasma. So you pass the blood, it will take out the plasma from the blood, and let's say we give him more FFPs. I'll take one class with you for the blood products. What is the blood? What is FFP? What is cryopreservative? What is PEG cell volume? So when you give him FFPs from another patient, and you are taking plasma from this patient which is bad, and you give plasma from a patient who's good, and you return it back to the patient. So his plasma is cleared. Let's say some patient came with high WBC counts. You attach to the plasmapheresis machine, not plasmapheresis. Now you basically freezing, but now you are removing WBCs. You remove the WBCs, you return the patient's blood back. So his blood is back, his platelet is, everything is back except the WBCs. You want to remove platelets. Khalas, you send to the patient this one. You put a filter that removes platelets, then you send the blood back. So it can do anything. It can remove any one component from your blood. Likewise, you can even remove stem cells. You can pass the
For the
blood, but stem cells are there in the blood.
Stem cell. Yeah, we can.
Stem cells are there in the blood.
No, we can stimulate them.
We can stimulate them. So stem cells are never in the blood. So we stimulate by giving GCSF, filgrastim. When you give filgrastim, the blood will push, the marrow will push your stem cell. It will come in the blood, and you can pass it through the machine, take them out, and send the patient blood back. So you can do like wonders with this. Just one point came to my mind. Your PEG cell volume, always remember, we give blood considering it's just blood. You should always remember that your blood, this one PEG cell you receive, it has around 300 ml of blood. Okay. So what you are doing, you are actually giving this patient fluids. So let's say I'm giving 2 PEG cells. I'm transfusing 600 ml to a patient. If some patient is in volume overload, or his EF is low, or he is elderly patient. Elderly patients their whole body is not really active to adjust the blood. So if in normal person, me, you, him, anyone, if you transfuse blood, our whole body is accommodated. Yani it will adjust. If you give more fluid, less fluid, my body will adjust. But elderly people, they're not able to adjust. So let's say a patient is 70 years old, more than 65 years old, don't go and give them like 2 pixels in 4 hours or 1 pixel in 2 hours, because you will give so much volume, 300 ml you push in their system, they will not be able to accommodate, and all will collect, fluid will collect in their lungs, and they will become short of breath, ICU. Okay, so elderly patients, be careful, give them very slowly. How slowly can you give a how slowly can you give a blood product? How long?
4 hours.
4 hours. 4 hours is the limit. In actual, 4 hours is the limit. The blood bank, from the blood bank, when it is released, it should be used. It's not the transfusion, infusion 4 hours. Once it's out of the fridge, it should be consumed in 4 hours.
Yeah, 4 hours also for transfusion.
Huh?
4 hours for transfusion.
Yeah, so basically, but what we are keeping, so just make sure it's not like your blood is here in the ward and you're transfusing after 1 hour and you're giving in 4 hours. So if the blood is here for 1 hour, you only have 3 hours remaining. Okay? So this is very important, because the blood product, when it comes out of in the freezer, in the blood bank, your blood is stored at 4 degrees centigrade. What temperature do you have here? 20, 25. So it's out. And if you don't use the product in the same time, and how, let's say you bring the blood bag here, and khalas, you're not transfusing the patient, there is some decision. How quickly this blood bag should be back in the blood bank?
As soon as you decide.
Maximum. Otherwise, khalas, your product is gone. You cannot return.
An hour.
30 minutes. In 30 minutes, that bag should be back in the 4 degrees centigrade. Khalas, otherwise, technically the blood bank should reject the blood. It's out more than 30 minutes, we will not take it. Okay? This is the normal thing. So this one thing I want to teach you guys, very important, that blood is always a volume. Don't ignore it. If you are giving like 300 ml, give it slowly. Adult patient, give it slowly. And then we can keep one session with the blood reactions. There are 4 or 5 types of blood reactions that are sometimes life-threatening. So this is important. The FFPs, how much do you think is the FFP you transfuse to your patient? How much ml is one FFP bag?
250 to
250, around 200 to 250. So if you're transfusing 2 or 4 bags, just consider how much volume you are giving to a patient. Like say someone orders, give 4 FFPs. Khalas, you go and put 4 FFPs. You're transfusing 1000 ml to a patient.
Yeah.
Right? You may think if someone is ordering 1 liter of fluid, and you will maybe ask the doctor, khalas, I give him bolus, or you want to give slowly. But FFPs, you'll go and you will transfuse.
And we had it before. We had it with overload.
Always remember, the blood product is a volume. Don't just think of it as a blood product. It's a volume you are giving to a patient. Someone has low EAF, you have to be careful that, and you should know generally, like platelets usually are 30 ml, 40 ml, 1 bag. If you give 6 bags, 150 ml, 200 ml, no problem. You can give quickly. You shouldn't even care. FFPs, no, I have to be careful. Blood, I have to be careful.
One last question, Doctor, regarding Ibrahim Al-Akhdar. When he admitted, his blood was...
Yes. Viscous, thick.
It was
because
thick.
of IgM. I told you, IgM. Let's say this is the size of IgG, so this is the size of IgM. IgM is very big molecule. So if you have a lot of big molecules in your blood will become very slow and thick. So it has its own problems. Yeah.
Okay.
I hope that's okay. Any questions? Khalas? I hope you understood.